Well, hello and welcome to the Diabetes Research WA National Diabetes Week online presentation. This is our first online presentation, so it's really exciting on a lot of levels. This presentation is entitled Diabetes and Pregnancy, a Future Vision for Australian Women and Their Families. And we're incredibly fortunate to have three wonderful women today sharing their knowledge with us. So thank you, ladies, for joining us. For those of you I don't know, I'm Cheryl Westland from the Diabetes Research WA. I've been with Diabetes Research WA for about 24 years, so research and diabetes is my passion. So before we commence, I thought I'd touch on a couple of important things that, first of all, this research project that we're going to be talking about today was funded by Diabetes Research WA in late 2019. So it's wonderful to be able to just deliver back some of this information to you so quickly. And obviously the research project itself can only be funded by the generous donations of people in Western Australia. So I'm really, really proud of that aspect. We're going to debunk some of the myths around diabetes and pregnancy today, pre-diabetes and the impact this can have during pregnancy, and reveal how research is aiming to transform the detection and management of gestational diabetes into the future. Our impressive lineup of presenters include Erica Spry, a Bardi Jawi traditional owner, an Aboriginal researcher from the Kimberley Aboriginal Medical Service, an adjunct research fellow with the Rural Clinical School of WA and has experienced gestational diabetes. We have Emma Jamieson from the Southwest, researcher from the Rural Clinical School of Western Australia, and Associate Professor Julia Marley, also from the Rural Clinical School of Western Australia. Before we start, please load up your questions into the Q&A box and we will answer those at the end, time permitting, of course. And I'd like to hand over to Erica now, who will give a welcome to country. Thank you, Erica.
Thank you, Cheryl, and again, thank you, Diabetes Research for Western Australia. I would like to extend everyone that is joining us here today a warm welcome, and also begin by doing the welcome to country and acknowledging the traditional owners on whose land we are presenting from today. So myself and Julia Marley, we will be presenting from the traditional lands of the Yaru people up in Broome, up in the north of Western Australia, and Emma Jamieson will join us from Bunbury down south in the lands of the Whadjuk Noongar people. And we pay our respects to all the elders, past, present and future here today. The diabetes is a metabolic condition that happens when you have too much blood glucose. While we need glucose for energy, too much is toxic, and we can cause, and this can cause heart disease, blindness, amputations, and kidney disease. Management of diabetes can prevent these complications from happening. Pre-diabetes is when blood glucose levels are high, but less than that of diabetes. Having pre-diabetes means that there is a high risk of developing diabetes in the next 5 years. Both pre-diabetes and diabetes can be reversed by making positive changes to your lifestyle. Every time you have a meal and drink sugar-based drinks at breakfast, lunch, dinner, and snacks, you bring glucose into the body. High blood glucose means more glucose floating in the blood. During pregnancy, you need to do an OGTT, the sugar drink test. The glucose attaches to the hemoglobin in your red blood cells. High blood glucose for a long time means more glucose can get stuck to the hemoglobin. The HbA1c test tells us about the amount of blood glucose attached to the hemoglobin over the last 3 months. In 2019 to 2018, 1.2 million Australians had diabetes. In Australia, there are higher rates of type 2 diabetes in areas that have high rates of low socioeconomic conditions. All persons, regardless of their ethnicity across the world, are at high risk of developing diabetes.
So with the rise in diabetes and the fact that mothers are getting older, we are seeing more women with diabetes in pregnancy, and it's estimated that 1 in 6 pregnancies worldwide last year were complicated by diabetes. Now, diabetes in pregnancy is broadly classified as either pre-gestational, meaning women have it before they fall pregnant, or gestational, where the high glucose levels are detected during pregnancy, but they're lower than in women with overt diabetes. Now, pre-gestational diabetes includes women with type 1, type 2, or more rarely, monogenic or specific types of diabetes. Gestational diabetes picked up during pregnancy can capture women with pre-diabetes at conception. As Erica mentioned, these are women that have early signs that they might go on to develop type 2 diabetes. Other women can have normal glucose levels at the start of pregnancy, but they start to rise in 3rd trimester. And the symptoms of diabetes are difficult to distinguish from normal pregnancy symptoms. That's why all women without known diabetes should be screened for high glucose levels during pregnancy. Now, about 16% of diabetes in pregnancy is classified as pre-gestational, but the rest is milder gestational diabetes. However, what's important to note is that half of the women with pre-gestational diabetes don't actually know they have it before they fall pregnant, and it's picked up during pregnancy. We also don't know how many women who are classified with gestational diabetes actually have pre-diabetes at conception. And remember, that's women who have slightly elevated glucose and are likely to go on to develop type 2 in the future. Now, who's at risk? Essentially, a lot of the risk factors for hypoglycemia in pregnancy are the same as those for type 2 diabetes. And these risk factors should be assessed at the very first antenatal visit. Now, all of these risk factors here are potentially modifiable, meaning we can potentially change these risk factors with preconception care. So women who are overweight or obese, smoke cigarettes, have depression, maybe have an unhealthy diet or inactive lifestyle, can change those factors before pregnancy. The next lot of risk factors are non-modifiable. So these are factors we can't really change. So women of non-European ancestry are at higher risk. The older you are, the more at risk you are. If you've got a family history of diabetes, if you've had previous pregnancies or currently having twins or triplets, you're at higher risk. And also if you've got underlying medical conditions like polycystic ovarian syndrome, or you're on corticosteroid or antipsychotic medication, these can increase your risk of gestational diabetes. Now, a lot of what we know about diabetes in pregnancy comes from women with type 1 diabetes. So these women can't make their own insulin, so they have to inject it. And insulin has many roles, but its most important role is to take glucose out of the bloodstream and put it into cells. Now, we have the amount of insulin injected per day on the left and the average glucose levels on the right. And through pregnancy, these women were able to keep their average glucose levels within quite a tight normal range. However, to do so, they had to increase the amount of insulin injected. I'm going to jump in here now to let you know that I've had type 1 diabetes for over 30 years, and I also have 3 boys. And by the end of my pregnancies, I was having to inject twice as much insulin as I did before I fell pregnant. Now, the reason we need to inject more insulin, or we need more insulin in pregnancy, is quite complex. It's due to an increase in the pregnancy hormones from the placenta and cytokines, or messengers that are sent out from the mother's own fat stores. And these combine to make insulin less effective. So you need more of it to keep glucose levels within the normal range. Now, earlier we mentioned women with gestational diabetes who develop high glucose levels later in pregnancy. One of the reasons we think some women develop gestational diabetes is that the cells that make insulin are not able to adapt, and as a consequence, their sugar levels go up. So before we go further, I just want to say or point out that when we talk about diabetes in pregnancy, glucose gets a pretty bad rap, but it's actually essential for the development of the baby. So it's really just about getting that balance right. Now, too much glucose at the embryonic development stage, so that's in the first 8 weeks of gestation, can cause defects in the developing organs called congenital anomalies. Now, these outcomes are rare, but they can have devastating consequences. So in Australia, 3 out of 10 stillbirths and neonatal deaths are due to congenital anomalies. Newborns who do survive may require multiple surgeries to correct the defect. So what we do know is that if a woman with type 1 or type 2 diabetes receives preconception care to help stabilise glucose levels before they fall pregnant, then we can avoid these congenital anomalies. But what about those women who have diabetes but don't know it? They often won't attend for their first antenatal visit until they're about 6 weeks pregnant, by which time the developing embryo has already been exposed to high glucose. So it's really important that we improve our preconception screening for diabetes in high-risk women. Now, what are the outcomes for women who don't know they have gestational diabetes, so milder glucose during pregnancy? We know that too much glucose during fetal development can lead to big babies. And by mid-gestation, babies start to make their own insulin. And if they get too much glucose from mum, they respond by making more and more insulin, and they grow bigger and store more fat. So this data that I'm about to show you is reproduced from a large international study called HAPO, which looked at pregnant women who did not have type 1 or type 2 diabetes. And these women all had glucose measured after 24 weeks gestation. We might need to click on, sorry, Julia, there we go. They were grouped into 7 glucose categories from low to high. And as glucose levels went up, so did the risk of having a large baby. And this continuous increase in risk has been seen in other studies, and there are no clear cut points to define who has gestational diabetes and who does not. High glucose is also associated with adverse outcomes linked to delivering a large baby, such as caesarean sections and shoulder dystocia or birth injuries. Now, high glucose levels in women with gestational diabetes normally disappear soon after delivery, but these women are up to 8 times as likely to go on to develop type 2 diabetes, with a high rate of progression in that first 5 years post-delivery. Babies are also more likely to become obese, even as early as 10 years of age, and they also have a higher chance of developing diabetes. Now, we've talked about all the bad things associated with diabetes in pregnancy, but it's not all doom and gloom. We know that we can manage sugar levels to keep them as low as possible during pregnancy. We can have a healthy diet and exercise, and with that, we can improve outcomes. We also know that after pregnancy, we can prevent or delay progression to type 2 diabetes with healthy lifestyle interventions. And I'm mindful of the fact, we've got over 50 participants out there in the audience today, that there might be some women who have diabetes and are pregnant and worried about what might happen. And earlier I mentioned that I have type 1 diabetes, so I just wanted to share a photo of my 3 crazy boys. In terms of my sugar levels during all of my pregnancies, they were probably the best they've ever been in my life. My first pregnancy was ticking along nicely. Then at 37 weeks, I developed preeclampsia, which is also one of the conditions associated with diabetes. And I had to be induced and ended up having an emergency Caesar. With my younger 2, I was induced 2 weeks early, but had normal deliveries with both of them. My eldest was 3.5 kilos. My other 2 were both over 4 kilos, so a bit on the big side, but none of them currently have diabetes. They're all fit and healthy. They play sport, and they've grown up doing all the regular things that kids do. And on that note, I'll hand over to Erica.
Like Emma, who has so kindly shared her story, I too will tell mine in the best interest to share awareness of diabetes, which in my case is my story of having GDM. I'm a mother of 4 amazing children. I have 3 sons and 1 daughter. With my third child, my second son, I got diagnosed with GDM between my 28-week antenatal checkup. On my personal reflection, I remember the convenience of sugar, food, and drink options that were available at various fuel and store outlets. With advice from my midwife and dietitian, I managed to relook at my diet, rethink what I should eat and drink to prevent and cut down on my sugar intake. I self-monitored my blood sugar by a finger prick point of care measure before a meal and 2 hours after. This point of care every day for up to 6 times per day, I didn't like it, and it scared me as I didn't want to develop full-blown diabetes. At first, I found it hard to accept I had GDM, but with each day's food and drink intake, I learned I needed to self-care for my unborn baby and myself. Fortunately, with exercise and as I controlled my diet by learning to read food and drink labels for sugar content, I avoided the need for medication. That assisted me to have a normal delivery with my son, and with my very last pregnancy, my last son, I managed to avoid GDM. Being an Aboriginal person, I know I am at high risk of developing type 2 diabetes after my GDM experience, and I know it is important that I work with my whole family for all of us to avoid diabetes. So my fellow Kimberley Regional Aboriginal people are diverse and many, with over 26 different languages. One common theme for Aboriginal Australians is that we are people that care for our country and care for all families and all ethnicities. One of our mottos, healthy country, healthy people. Across Australia, there are over 350 different Aboriginal people. Unfortunately, over 30% of Kimberley Aboriginal adults have type 2 diabetes. The management of diabetes is a long-term health priority for the Kimberley Aboriginal Community Control Health Services shown in this video. Several factors influence how Aboriginal people understand and manage their diabetes. This includes the effects of colonisation and the dislocation from country, lack of trust in non-Indigenous health staff who have limited understanding of Aboriginal culture, and fragmented care with multiple services providing healthcare. This is made worse by low socio-economic conditions, including overcrowding, poor access to nutritional food, and the undervaluing of traditional bush medicine practices and traditional seasonal foods. We also live in an obesogenic environment whereby health promotion usually targets the individual, not the systems that influence an individual's behaviour. You might have heard about the current inquiry into the cost of food in remote WA communities. This is an example of how social determinants of health, things that you can't control, having an effect on your health and well-being. The Kimberley Aboriginal Medical Services are a member-based organisation that support and represent the interests of 7 independent regional Aboriginal community control health services. In the Kimberley, our diabetes story begins with the screening for diabetes 2011 to 2013. The point of care HbA1c study took place. This study showed that HbA1c was better than glucose for diagnosing diabetes for Kimberley Aboriginal people. Then in 2014, 2015, in the Kimberley region, the implementation of the HbA1c screening began. During the development of the new guidelines for screening diabetes, one of the clinicians asked if we could use HbA1c during pregnancy because there were known problems in completing the OGTT. This led to the ORCID study.
So ORCID stands for Optimisation of Rural Clinical and Haematological Indicators of Diabetes in Pregnancy. We like the name, so we came up with something to fit. We sometimes slip up and call it the ORCID study. So this started off as a rural clinical school project, and this map here shows the locations of where the rural clinical school is located in Western Australia. There are extra sites since this map was developed, but also this is what the sites when we started this study. So as you can see, there's huge distances in rural and remote Western Australia. There's less resources, poorer health outcomes, and so the rural clinical schools were set up across Australia to teach medical students in the second last year of their training, and to hopefully then lead to an increase in doctors living in rural remote locations in Australia. So saying this project started off as a Kimberley Rural Clinical School project, but during development we asked if other sites would like to be involved, and so they joined up. Oh, the other thing just to mention around the rural clinical school, so it started off first with teaching students and then research came along later. So we prioritise research that's important to the regions and that will lead to improvements in health outcomes. And we're also very closely tied with all of the local medical services. So in the Kimberley, with the Kimberley ATROs and WACS, WA Country Health Service. So going back to GDM, so as Erica showed before with the type 2 diabetes increasing around the world, GDM incidence is also increasing. So there's a few reasons for this. Partly it's around universal screening wasn't introduced until 2012, and so we have a big increase after that. And so we don't really know what our rates are before this because it was risk-based, and a lot of women can still develop GDM who have no risks, apparent risks associated with GDM. In 2014, the guidelines changed, and it took a while before it was these new criteria were included on the pathology reports. So that's probably a little bit of a reason for this lag here. But the other thing is that around this time, clinicians were saying that a lot of women were not, that they were seeing, were not doing the OGTT. So one of the things around, I guess, with also with the development of type 2 diabetes, with the whole social determinants of health, is that a lot of your health today is dependent on your health of what your mother ate or didn't eat during pregnancy. It actually goes back in 2 generations to what your grandmother ate or didn't eat during pregnancy. So your health today is dependent on what was happening in the 1960s to 1980s. So the stolen generations were still occurring. And so this also works going forward. So your health going forward can impact, so if you're pregnant today, it'll impact on your children and your grandchildren as well. So first off, we wanted to see whether or not the reported low rates of screening was true. So we did an audit on the uptake of universal screening with the oral glucose tolerance test, so the sugar drink test. And as was reported, so the anecdotal evidence from the clinicians, we actually had poor screening rates. Only half of the women were screened with the OGTT. And one of the things that surprised some of the clinicians from down south was that how poorly their own clinics were doing with this. So some clinics were doing really well, and that was across the board. But also a lot of clinics were doing quite poorly. So it wasn't just an Aboriginal Northern Australian issue with poor screening rates.
We aim to recruit women statewide from rural and remote Western Australia, including Aboriginal populations in our study was important. 600 participants completed our study and delivered at 30 weeks gestation. 39% of the 600 women were Aboriginal. Aboriginal women enrolled from the Kimberley, my region, were the second largest numbers recorded in the state. Our Aboriginal women are at high risk of GDM. From these graphs, you can see from our study, Aboriginal women were more likely to be obese, have more children, and have a family history of diabetes. Here we show when Aboriginal and non-Indigenous women completed routine screening for an OGTT during pregnancy and who were diagnosed with GDM. This is the recommended screening period in Australia, the 24 to 28 weeks. As you will note, non-Indigenous women were more likely to be screened during the recommended period than Aboriginal women. Consistent with the audit, non-Indigenous women were more likely to complete screening. Some women attempted an OGTT but did not complete, declined, or vomited. Aboriginal ethnicity was the only factor significantly associated with not completing the OGTT. Despite Aboriginal women being at higher risk and other studies showing higher rates, there was no significant difference in GDM rates in our cohort.
These results puzzled us. Firstly, because we'd expected a much higher overall rate of gestational diabetes, or at least an increase following implementation of the new diagnostic criteria. Secondly, we'd also expected to see a higher rate in our Aboriginal women, as had been shown in other studies. So when we looked at 495 women from our study who would have also met the criteria for that large HAPO study, our GDM incidence was significantly lower, but our babies were larger than in HAPO. So something didn't quite add up. So we decided to investigate. And one thing we did was look at the number of women in each glucose category. So you remember I showed you before in the HAPO study that women were grouped into 7 glucose categories, from lowest being category 1 to the highest being category 7. Now this shows the proportion of women in each category for the HAPO study. When we looked at the ORCHID study, almost half of our women fell into the lowest glucose category, and we had very few women in the highest category. So it was like the glucose levels in our study had all shifted down. Now, you'll also remember that I showed you earlier, as glucose levels go up, so does the risk for having a large baby. When we looked at our data, we saw that women in low glucose categories, so categories 4 and 5, had over 20%, or a 1 in 5 chance of having a large baby. And that risk was only seen in women from the HAPO study in the highest glucose category. So after looking into this in more detail, we now know the reason why. So it turns out glucose is not stable in blood samples. The reason is that the cells, predominantly the red blood cells in a sample, are still alive after collection, and they continue to burn glucose as a source of energy. Now, we've known about this for decades, so we use collection tubes that contain fluoride, and fluoride stops the cells from burning glucose. However, it doesn't work straight away. So Julia, could you please click forward for me? There we go. So this is data from 10 ORCHID study participants who had extra samples collected at the same time as their glucose tolerance test. Now, when fluoride samples are kept at room temperature, so that's the red line, glucose drops over the first 4 hours. In the HAPO study, the study design, at the time, they knew this would be a problem. So they put the fluoride tubes on ice and made sure they were processed within 1 hour, which slowed down the loss. In Europe and America, tubes that contain fluoride and citrate are now recommended for use because they stabilise glucose immediately. Now, in the ORCHID study, most samples arrived 4 hours after collection. So when we went back and corrected our results for the estimated loss in glucose, we found that 62% of the women with GDM were actually told their glucose levels were normal because of a delay to analysis. And when we went back and looked at our change in risk for a large baby, we saw that it now started to line up better with the HAPO study.
Okay, so this is that graph, but flipped on its side with the rate of large babies per glucose category. So if you use, as you can see, it's a linear curve and there is no definitive cut point, but the experts decided that they would pick a cut point at which your risk increased by 1.75 times. So if you follow the HAPO study process, pre-analytical process of storing your blood samples, you'll get 25% GDM. In the real world, we only get 11% GDM. If we use IFC mixed tubes, we'll get around 30-35% GDM. So people have been saying, oh, what happens if you get an overdiagnosis? You'll get an overdiagnosis here. But the issue is it's a continuous increase in risk. So this is a problem of we're having a cut point that says you either have GDM or you don't have GDM, but your risk increase is based on your level of glucose. So we need to really shift the way we think about this, away from a disease that you either have GDM or you don't have GDM, and we'll manage you differently if you have it. So actually thinking about, well, what is your overall risk of having adverse birth outcomes? To take away the stigma also of having GDM, because you can do everything you're supposed to do and you can still get GDM. So it's not necessarily a woman's fault for developing GDM. And we also need to think about it more as like looking at the whole family approach for it. But certainly changing it from you either have a disease or you don't have it to saying, well, what is my level of risk of having adverse outcomes? So when we found all this information about glycolysis, we were kind of asking other people saying, do you know about this? Do you take into account, we've been told by these experts that everyone takes into account that there's glycolysis. And we spoke to a lot of people and they all said, no, we had no idea. And the one person who did know about it said, oh, but it's not going to have much an effect. But as Emma said, we've got a 62% underdiagnosis. Also, because it's such a complicated test, there are so many factors that can go wrong. You have to fast, you have to wait around for those 2 hours, women vomit. It's a really complicated pre-analytical process for handling the bloods, which makes it quite complicated and a lot of extra work in really busy clinics, especially in remote Australia. And all of these pre-analytical processing, they weren't addressed when the guidelines were changed, which is contrast to Europe and the US, where they actually highlighted the issue around how the blood samples should be stored. But when we asked for the Australian guidelines to be updated, it was like, oh, that's got nothing to do with us, that's pathology. So one of the things that we've kind of put together, kind of thinking about, well, what went wrong in this, is when you're designing research, you need to actually consider what's feasible in the real world. And is there any implicit knowledge that's going to impact how things will get implemented? And when changing policy, what is the opportunity cost? Is it really beneficial to insist on a gold standard test that's difficult to do, and women are less likely to do it, than having something that's not quite as good, but it's much easier to do and more likely to actually have the test done? And no one's monitoring implementation. So who should be responsible for this?
We completed the small study using the FC mixed tubes with Broome Regional Aboriginal Medical Service, BRAMS, highlighted here on the map by the star. We'd like to thank BRAMS for their involvement in the study using the FC mixed tubes, as this was crucial for convincing Kimberley sites that we needed to change how the blood is collected. Last year, from September 2019, all Kimberley Aboriginal Community Controls Health Services and some Western Australian Country Health Services, WACS, adopted the use of these FC mixed tubes for all pregnancy OGTTs.
Okay, so the whole glycolysis kind of really threw us off and kind of delayed the project by at least a year. So we were now able to go back to our original hypothesis, our original aims of the study. And one of them was seeing, well, early HbA1c, could we use that to predict women at risk of developing GDM? So one of the first things we looked at was screening. So as you can see, even though Aboriginal women had higher risk and more were recommended to do an early OGTT, very few actually did the OGTT as an early test. But early HbA1c, Aboriginal women were more likely to complete it much earlier than non-Indigenous women. So quite early on in the development of the project, a few of us placed bets on the different markers that we were looking at. And mine was on the utility of the early HbA1c in predicting risk. So that's where my money went, but we didn't actually place any money on the bet. So because of COVID-19 and there's a bit more knowledge about epidemiology out there, I thought I'd throw in a couple of technical slides. So one of the things when we're looking at, especially setting up a new diagnostic test, is what threshold do we use, what cut points? So one of the techniques we use is the receiver operating characteristic curve. In an ideal situation, the difference between having a disease and not having a disease, the population's really quite spread out, and you get this really nice curve that you have high sensitivity and high specificity. It means that you really know when you say someone has a disease, they have the disease, and when they don't have the disease, they don't have a disease. So if you think about COVID and what happened to the Irish footballer who had COVID, didn't have COVID, had COVID. So that's, when there's issues around the sensitivity and specificity of a test. No test is 100% perfect. You're more likely to get results like this. And this result basically means flip a coin, you're going to get as much information out of that as to do the test. So what happened with early HbA1c? Okay, for our non-Indigenous women, it's along this line. So that's the flip a coin, not very useful. However, for our Aboriginal participants, it's actually looking quite good. And so we decided to pick on a point that gave high specificity. So this means that they really did have GDM, rather than going for high sensitivity, which is ruling out. So women would not likely to develop GDM. So what impact does this actually have when we look at the GDM and the birth outcomes? So within the Aboriginal cohort on the OCUD study, so looking at just the women who completed both the early HbA1c and the routine OGTT, so the 24 to 28 week OGTT, 76% of Aboriginal women had a normal OGTT after we adjusted for the glycolysis. And so 24% had GDM. But there was actually a range of different outcomes in this group of women with GDM. So over time, our thinking has changed a lot. We've been doing more work on pre-diabetes, and also the criteria has recently changed, and it's only because some information came out about changing screening during the COVID-19 lockdowns. So we have a different HbA1c cut point for detecting pre-gestational diabetes, that's 5.9. And so rather than thinking about, well, half of the women who develop GDM, we can pick up early in pregnancy, actually, these women have pre-diabetes, so they were having higher glucose levels prior to the pregnancy. And half of the women develop GDM, which also shows that we do need to have screening at 24 to 28 weeks. And this pattern of higher rates of adverse birth outcomes, so in this case, large for gestational age babies, went across all of the cohorts, so including non-Aboriginal women. So even though that ROC curve looked like it was pretty useless for non-Indigenous women, I think it's because we had so few with pre-diabetes. So the higher your glucose levels and your HbA1c levels early in pregnancy, the higher the risk of adverse birth outcomes. Emma.
Right, so we know we can use HbA1c early in pregnancy to improve detection of women with pre-diabetes, but how can we improve detection of women with gestational diabetes? So again, going back to the issues with glucose testing, the first and most important thing we can do is improve glucose stability. So just going to the next slide. When we do this, we pick up more women with gestational diabetes. So you just click forward, there we go. So when we improve glucose stability, we pick up more women with gestational diabetes, but we're also identifying more women who are at high risk of having at least one adverse birth outcome. But the question is, what can we do for women who develop high glucose during pregnancy, but they decline or are unable to complete a glucose tolerance test? So we wondered whether we could use HbA1c later in pregnancy. Now, HbA1c can be altered by anemia and the blood volume expansion that happens during pregnancy. In the ORCHID study on its own, HbA1c was okay at identifying women with gestational diabetes after 24 weeks gestation. However, we can combine a HbA1c result with measurement of glycated albumin. Now, glycated albumin reflects glucose over 3 weeks, and it's not affected by anemia, and it's less impacted by the changes in blood volume. So for the ORCHID study, we were really fortunate to have in-kind support from Asahi Keisai, the Japanese pharmaceutical company that make glycated albumin kits. Also, the beauty of measuring a HbA1c and a glycated albumin compared to an OGTT is that women don't need to fast overnight. They can have the test done at any time during the day. They don't need to drink a glucose challenge or sit in a collection centre for 2 hours. So compared to the oral glucose tolerance test, we think more women will actually have a HbA1c and glycated albumin done. Now in ORCHID, we combined the two tests to stratify women as low, medium or high risk for gestational diabetes. And this was according to the glucose tolerance test results that were adjusted for glucose instability. And over half of the women in the high risk group had gestational diabetes. Now, when we look at if these women have at least one adverse birth outcome, we can see that the risk for adverse outcome in the high risk group is almost double the risk for women in that intermediate risk group. And this holds even if after we account for maternal body mass index, age and ethnicity. Now, notably, most of the adverse outcomes in the intermediate risk group occurred in women who would have probably tested negative by the oral glucose tolerance test anyway. So we're in the process of validating this risk stratification strategy alongside glucose tolerance tests collected into the fluoride citrate tubes that stabilise glucose immediately. And we're very fortunate to have received funding from Diabetes Research WA to do this. If the cut points hold, we believe that we can use these two tests to eliminate the need for a glucose tolerance test in the high-risk women who would go straight to management, and in the low-risk women who would just receive standard antenatal care. And we could then focus the glucose tolerance test for women in that intermediate group. Okay, moving on to Julia.
Okay, so I think we've shown categorically that the OGTT is failing women in rural and remote Western Australia. A lot of women decline to doing it. It's complicated. We're getting a significant underdiagnosis of GDM. We need to change across the board for using FC mixed tubes to actually deal with this. But it's still a really, it's still a test that women don't want to do. Clinicians find it hard to try and encourage women to do it. I think we've also demonstrated that early pregnancy HbA1c for Aboriginal women identifies a high risk group. So specifically with identifying pre-diabetes. I think this is actually quite important. So, and that can change how we think about management of that. And as Emma has just shown, HbA1c and glycated albumin can use to safely stratify risk.
So where to next? Well, we have our audits ongoing to revalidate early HbA1c and the impact of the FC mixed tubes. Emma and I have in place the ORCID study phase 2 study packs across our sites in Western Australia, again for revalidation of the HbA1c and the GA cut points, funded again by Diabetes Research of Western Australia. As you can see, we're not short of ideas, and we are exploring preconception care as a whole of family prevention, screening for type 2 diabetes, pre-diabetes, and encouraging a healthy lifestyle for everyone. Prevent pre-diabetes. So the management of pre-diabetes in pregnancy, we need to look at the timing of when to start management. How do we manage pre-diabetes? What targets should we be aiming for? Is this management effective at reducing risk of adverse birth outcomes? And my very one that I'm keen to move on more is what becomes of the GDM mother and baby long term? We need to ensure that ongoing care is available to the GDM mother after birth and baby. And on wrapping up, we would like to again acknowledge and thank all the wonderful midwives and clinicians who are assisting us with our study.
So just final acknowledgements. So these are the logos of all of the participating services. I think it was 27 in total. And I also would like to acknowledge and thank all of the women who participated in the study, and our clinical investigators who we'll be going back to soon to discuss around the management and how we change our guidelines. One of the benefits of being in the Kimberley is we have our own protocols, and so we can update them based on our research. Also, I'd like to acknowledge our funders. So the Royal Clinical Schools started this off. Lishman Foundation funded Emma's salary to start with. Erica started off on NHMRC CRE Isaac, and then Diabetes Australia. Huge support from the Kimberley's services. Hi Casey, and I pronounced that wrong, for the kits. And last but not least, Diabetes Research WA for our next phase. And if you would like to know about any sources, leave this up for a couple of minutes. This is where you can get more information about diabetes in pregnancy. And on the CAMS website, we have our research projects. So we've recorded this presentation, and we will be making it available, and also the links. And also you can contact Shirl for these links as well. Thank you.
Fantastic. Thank you very much to all of you for your presentation. Erica, Emma and Julia, that was really informative. I learned so much, and I think what's really powerful is to know that where we are today in our own health is actually, you know, something that has come about from previous generations, and so therefore going forward we have that opportunity to change future generations through health and well-being. So we've got a couple of questions that have come through, which is terrific. I've got one here that says, what makes psychosocial factors such as depression a risk factor for hypoglycemia during pregnancy? Is it due to behavioural factors or something physiological?
I might start on this one. A lot of it would be physiological. So with depression and anxiety and things like that, you get an increase in corticosteroids, cortisol, and so then that will then impact on insulin and diabetes and the metabolic kind of processes. So yeah, it is a physiological impact, and there's also impacts on depression and in terms of, you know, having a healthy diet. So if you're suffering from depression, it's harder to go and make sure that you're having a healthy diet, but a healthy diet can also help with depression as well. So it's quite complex in that interplay. But so stress levels for the mother during pregnancy certainly has a wide range of impacts on the development of the baby.
Wow, that's it's really important, isn't it? That sort of that whole holistic look at pregnancy and mums and babies, etc., and the environment. I've got another question here. Should HbA1c be a standard for all preconception consultations?
Yes, definitely.
Yes?
Yes. It's something that we're trying to push in the Kimberley. It's one of the areas that we're looking at around, because we have annual screening, but we know that because diabetes rates increase as you get older, it tends to be the older patients will have more regular screening. So it's more around really encouraging screening in younger people. And it's also, we're just pulling this information together in terms of the impact. So over another one of our projects is actually looking at progression to type 2 diabetes. So we will be looking at the impact of HbA1c prior to pregnancy, during pregnancy, and after pregnancy, as well as a subset analysis within that. So we'll be able to have more information in the long run, but certainly, yes, very much encouraging HbA1c as preconception counselling.
Wow, the more information we have and the more ability we have to make changes and, you know, seek the right care, etc.
Yeah.
Do you think you'd see the similar representations of those figures on the graphs in bigger cities and in Perth, etc.?
The rates are usually lower. So as with all kind of health outcomes in non-urban centres in Australia, health outcomes are worse the further away you go from a metropolitan area. That's not to say that there are areas within cities in terms of like low socioeconomic areas. There will be higher rates in those kind of areas, but I guess social determinants of health play such a big role in development of GDM, progression of diabetes. But there is the other thing of, even if you do the right things, you still and have no risk factors, you can still develop GDM. So while the rates will be lower in the cities, there will still be GDM. Yeah.
I think that's a really powerful point, isn't it? That there are things that are going on with hormones, etc., and changes during pregnancy that are impacting those blood glucose levels, etc. So let's hope we can sort of push forward on that. I do have another question here. Some mums might be concerned about having the glucose test when worrying about impact on the baby. Do you have anything, any information on that?
It's just one load at one particular time. So there's no evidence to say that one particular load will have any impact.
Right.
So I guess it's until we come out with our new screening of glycated albumin and HbA1c, we are still recommending doing the OGTT. We know it's a pain, and it's not the best of tests, but that's the only way at the moment that we can really identify those at risk. But the thing is, even if your result is negative or normal, you can still be at risk of adverse birth outcomes because it's a linear relationship. That quite often is lost in practice and in understanding, because the discussion has always been, you have GDM and we're going to do all these things to you, or you don't have GDM, here's a bit of information about nutrition and a healthy lifestyle, and we're not going to worry about it, where it's a lot more complicated than that.
Much more complicated, as diabetes is, that we've discovered with lots of research. It's a very complex and complicated disease in all types. Do you think that the results or the changes could be rolled out to be used across all areas, not just in rural and remote?
Yeah, certainly with the HbA1c, the early screening, definitely. With the glycated albumin, it will take a little bit longer because we don't have a medical benefits scheme rebate, an MBS rebate for that test. And so part of the process would be around getting all the evidence and then building up a case to say, actually, we should be using this as a screening test. So we've done that before in the Kimberley, where we've kind of led the way with the HbA1c screening for type 2 diabetes, and that's led to changes nationally. And the other thing is with our protocols, they're available on the CAF website, the Kimberley Aboriginal Health Planning Forum, and a lot of other places use our protocols. So yes, so quite often we kind of lead the way in these things, and then they get picked up by other areas. So you can do, cutting edge research out in the bush.
Yeah, I think that is wonderful. That we know that there's great research going on out in the rural and remote areas. It's not just housed within the bigger cities. So I have a little comment here. Great presentation. Thank you. To what extent, as a remote community, are you able to involve the community in strategies for managing? I presume that's diabetes.
Yeah, Erica, do you want to talk about the lived experience?
Yes, so and this information I'm going to talk about is available on our CAM's website. So this was called the lived experience. So what happened is we went out and we involved our remote clinics, and we found that with participants that came on, they shared their story of living with diabetes, and they have been living with diabetes for up to this year 10 to 34 years. So they never had a voice before, and they spoke about what it was like for them, and we came up with recommendations for action. So they found that when the clinicians came in and did a consult, that instead of just jumping straight into their medical needs, that they got involved in a yarning process, and they started to hear the story of the person, and it sort of built up that comfortable space, a culturally secured space, so that they could share. There was a three-way learning when we did this with both the participant and the clinician learning about each other. Some of the highlights is what it was like with their food insecurities out there, the cost of living out in remote areas, and having access to the food that suits their diet. They asked about having support groups within their community, so they, outside of clinic hours, could all come together and share what it's like, and the different types of medications that they were on. If they were at a doctor's consult and they had a change in medication, what does that mean for that person, but also their family? What does that mean for that community as well? And the many families that we're finding that are starting to become more diabetic. So we're finding that it is continuing to grow right out in our remote areas as well, in our clinics. And so there's, like I said, we can go into a bit more on our website with the other areas that they've recommended, but there are some of the highlights.
And we're working with the clinics around, so some of the things have already been, I guess, implemented in that. Some of the clinicians have changed the way they work with the patients. And also we're looking at developing, different resources and, changing models of care and things like that. So because we're embedded in the services, so I also have a small fractional role with the Kimberley Aboriginal Medical Services, and we do our research in partnership with the services. We think about implementation as part of our research, and we're having the end users of our research involved in our projects right at the very start, so that we try and work out how we have that implementation go all the way through.
We also
that's just terrific.
Yeah, we also had the Aboriginal health workers as well. So it was the participant, the patient, it was the Aboriginal health worker or practitioner, and then the clinician as well. So there was a three-way, and everyone found that they shared, everyone benefited in their journey, because diabetes, once you have it, and that was the part of the paper, that it stays, it doesn't go away. you know, so it's this ongoing care that we need, what Julia referred to as the model of care here.
And I guess the other thing is just a plug for our other research that we looked at, the management of type 2 diabetes at Derby Aboriginal Health Service, and we looked over 10 years. And this is the only study that's looked at every single patient record over that period of time. And we showed significant improvements in patient outcomes and the delivery of care. So Aboriginal community controlled health organisations can deliver really good quality care, and they were kind of, the increase was comparable to non-Indigenous outcomes.
Yeah, this is just absolutely terrific, and I can sort of see that there's so many layers of, you know, improving the delivery and accessibility of healthy foods and appropriate foods as well, and that food security is a major issue as well. We've just about come to the end, so just a couple of little things. Thanks again, ladies. Thank you for all the attendees and everybody joining in. That was just fantastic. There will be an email sent out, I believe, Julia, that will...
One tomorrow.
And then we'll have some links up as well for the presentation, which we'll get out to you as well. If you want to find out more about research, head across to our website, diabetesresearchwa.com.au, and you can find us all across social media. Just look up Diabetes Research WA. And thank you very much. I really look forward to the next instalment, ladies. Fantastic. Thanks very much for your time.
Thanks, Cheryl.
Bye.
It's a pleasure.
Bye.
Bye.